Very good afternoon to all of you. At the outset, on behalf of local organizing committee, I welcome you all for taking so much pain in extreme cold condition to come to Patna. You all know there is paradigm shift in the management of OSSN, especially after development of good chemotherapeutic agents like mitomycin C, 5-fluorouracil and interferon, and with advent of HROCT, again diagnosis of tumor is very easy. So I will not take much time. Coming to the management part, previously surgical management with basically typically it was required removal of tumor with wide excision and cryotherapy of the limbus or corneal surface. But in a study published in Expert Review of Ophthalmology, it was found that in 2003, only in 66% of cases were managed with surgery, while in 2012 it came down to 51%. In another study, why this medical management is important, it was found that even if there is negative margin on histopathology, chances of recurrence is high, as much high to 33%, compared to with positive margin in 56%. So why medical management is important? So medical management basically they treat whole surface and some area which are inaccessible, like palpebral conjunctiva, fornicage, caruncle, or there is diffuse involvement in which surgery is difficult, so medical management is helpful. There are surgical complications also, eye wall thinning, symblepharon formation, limbal stem cell deficiency in larger tumor. There may be corneal opacity also, and there may be damage to sclera, retina due to excessive cryotherapy. There may be pyogenic granuloma formation. So what are the agents that is available for chemotherapy? Most important one is interferon alpha 2b, 5-fluorouracil, mitomycin. Newer agent, some newer agent has also been quoted in some study, especially anti-VEGF, retinoic acid, and even aloe vera has been used for OSSN. So not going in detail about the mechanism of action. So coming to the first case, a 73-year-old male who basically father of my friend who presented with this large tumor, and so patient was taken and on OCT one can see the hyperreflective epithelium, and there is abrupt transition of normal epithelium to the abnormal to normal epithelium. So patient was put on interferon alpha 2b, and after 1 month one can see the size is decreased. After 3 months and after 6 months lesion has gone. So in second case, again this was very large tumor involving the upper part of the cornea, bulbar conjunctiva, fornicage, and palpebral conjunctiva. This patient was put on mitomycin C 0.04%, and at 1 month again lesion decreased in size, and after 3 months lesion has gone. In third case, again at presentation there was corneal involvement that was detected on OCT. One can see the thickened and hyperreflective epithelium. So again at 1 month lesion decreased, and at 6 months due to residual opacity is there, but lesion is gone. In case 4, again this was a case of xeroderma pigmentosa, and patient was non-compliant, and patient presented with recurrent OSSN. So initially we have started interferon, but patient was non-compliant, so again patient was shifted to mitomycin C. So after 5 months again lesion resolved. Fifth case again 51-year-old male, surgery was done outside and patient has presented with recurrence. So again patient was put on mitomycin C and it resolved after 5 months. Sixth case again the leukoplakic OSSN and patient was put on mitomycin C and after 3 months lesion improved. So coming to the result, all the patients were male in this series. 3 cases were papillary variant and 2 were predominantly leukoplakic and 1 was having mixed form. The average size of the lesion was 9.8 millimeter. 5 patients in the series were immunocompetent, while 1 case was with secondary to xeroderma pigmentosa. Approximate duration for resolution of the lesion was 4 to 6 months. 4 cases were primary OSSN, where 2 cases were recurrent disease. 4 patients responded to topical mitomycin C and 2 to interferon alpha 2B. So take home message is as surgery has been the traditional mode of treatment, but now with the advent of topical chemotherapy, one can start topical chemotherapy after knowing the extent and depth of lesion. And topical chemotherapy, it results in less scarring and stem cell loss is lesser compared to cryotherapy. Favored approach, especially in cases of diffuse and recurrent multifocal, again topical chemotherapy. And choice of which agent should be used, it depends on compliance, ocular surveillance involvement, treatment schedules, access to compounding pharmacy and the cost. Thank you.